So for massive GI bleeding, the majority of it, 75% is from upper GI bleeds. The causes, it's less common to be variceal, but that's when Blakemore tubes are usually indicated. It's more common to be actually non-variceal from ulcers. So just to give a quick overview, always start with your ABCs. And for an upper GI bleed, for airway and breathing, if they're hemodynamically unstable, their mental status is all altered, you're worried about them aspirating and protecting their airway, you want to intubate. And for this, it'd be preferable to probably start with DL versus video assisted, just because of the blood getting on the camera, obscuring your view. This would also be a situation where you'd probably want to use a bougie to just enhance your first pass success. For circulation, you want to view them, as a trauma. They're hemorrhaging. You need, 2 large bore IVs. You maybe want to put in a cordis, activate MTP early, and transfuse in a 1:1 ratio. Call for help. So the people you want to get on board early are obviously GI. You actually might want to also consider surgery if they're really unstable and the bleeding's not stopping, and then ICU. Coagulation reversal, if they're on any anticoagulation, you want to give them the appropriate reversal agent. If they have any coagulopathy, you also want to correct it. And then other medications, octreotide in patients with variceal bleeds, PPI, and then ceftriaxone if you're expecting them to be a cirrhotic for SBP prophylaxis. Okay, so just give an overview about the Blakemore tube. So this is basically a balloon tamponade that can be used to be bridged to definitive treatment for GI bleeding. The case reports, or case series report like a 60 to 90% success rate for hemostasis after deployment of the balloon. And it's pretty simple. It has 2 balloons, one at the gastric. There's one that goes into the gastric area, which is your gastric balloon, and then you have your esophageal balloon. In terms of the timing, if you're having massive upper GI bleeding, hemorrhaging that's not stopping, it's better to actually deploy one of these early unless GI is thinking of taking them right away for endoscopy. So you always first want to prepare your patient. So if they're not intubated, you need to intubate them to place a Blakemore tube. You want to ensure that they're sedated and paralyzed. This actually helps mitigate the risks associated with Blakemore tubes, such as like aspiration, asphyxiation. And then you also want to remove the NG tube that's already in place, because if you keep it in place, it's going to sort of obscure your placement of your Blakemore tube and the proper sort of ability for it to be able to tamponade the bleed. So you need to gather your supplies. At County in CCT, the Blakemore tube is in the Pyxis. I'm not sure actually where it is at UHB or if we have them. It comes with just the balloon, which is like that red with the yellow to the left. There's a list of other supplies that you need to gather as well. It's sort of long. You probably want to look it up. The most important stuff, you need to get an OG tube. You need 3-way stopcocks, as well as 4 dual lower lock caps. Those can be found in IV start kits. We actually had trouble finding them when we were actually trying to do this procedure. You need a Kelly clamp, as well as the other supplies listed here. In terms of the insufflating manometer, our blood pressure cuffs at County, the manual, you can't detach it to use it. So I talked to Dr. Beta, he's working on trying to figure out where that is, and it should be, we're gonna create a little kit to be with the rest of the Blakemore tube. So next you wanna prepare your tube. So that involves placing the 3-way stopcocks in the gastric balloon port and the esophageal balloon port. And then you need to check the balloon for leaks by inflating it in water. This would be both for the esophageal and the gastric balloon. And then you're gonna measure the OG tube at 2 points. And this is, you'll sort of see why you do this in a second. Basically, you're gonna measure proximal to the gastric balloon and to the 50 cc mark, 50 centimeter mark on the Blakemore tube. And on the OG tube, you're gonna mark that with a G. And this is all outside of the patient. And then you're going to measure from the top of the esophageal balloon again to the 50 centimeter mark on the Blakemore tube, and you're going to mark that with an E on your OG tube. So now you're going to, the OG tube that you had placed initially is removed, the patient's intubated, sedated, paralyzed. You're now ready to insert your Blakemore tube. So actual insertion, you can go through the mouth or the nares. The Blakemore tube is, it's not very stiff. It can be pretty difficult to place because it is large. You can use like DL to visualize and like assist with like alligator forceps to place it. I also saw some suggestions of like freezing it or putting in like ice water like we do with OG tubes that are difficult to place. And then there's also some suggestions of actually using a bougie, which you can like look up that technique. There was only one person or one resource I found, so I wouldn't say it's, you know, well studied, but you can get creative. So after you place it, you wanna basically insert it all the way to the 50 centimeter mark. Then there's a stomach port that will basically, you'll section out the blood that's already in the stomach using like a dual Christmas tree to connect it to just suction tubing. After that, you're gonna clamp with Kelly's, make sure that they're wrapped in tape because you could puncture the balloon otherwise. And then you're gonna inflate the gastric balloon with 50 cc's of air. Next, you need to confirm the placement. So classically, you confirm with a chest x-ray. You need to confirm that the balloon's below the diaphragm. That can be sometimes difficult to get like the tech over in a timely fashion. And if you have ultrasound, which we do, and you can't get the x-ray quickly, you can try to confirm with ultrasound first. This, you go in like the left upper quadrant, you're gonna there will be a lot of fluid and blood in the stomach, so you can use that as a window and fan back and forth. Oh, the videos didn't share. Okay, well, I had some, here we go. So this, you can see that hypoechoic is like the Blakemore tube, and all of that hyperechoic is like blood and blood clots. So you can see that you're in the stomach. And then, and now the next video. So then this is a video of them actually inflating the Blakemore, the balloon, the gastric balloon. So you can see that this is the balloon here, and you can see them insufflating it with air, and it's like you can basically insufflate under direct visualization. The gold standard, you still want to get the chest x-ray, but this would be a good way for you to like confirm you're in place before having to have like the x-ray talk run over and then going back and forth. Okay, so now that you've confirmed you're going to fully inflate the gastric balloon, you're going to add 200 cc's of air, so another 4 syringefuls, and then you're going to apply traction. And so you basically take gauze, a IV pole, and a liter bag of saline as a weight. Now you're going to check for bleeding, because now you basically tamponaded varices that would have been in the stomach or bleed that would have been in the stomach. So you're going to place the OG tube. You're going to stop basically at the pre-marked G. So you're going to then suction and irrigate the esophagus above the gastric balloon, and this will be telling you if there is esophageal bleeding that you need to tamponade. So if there's no ongoing bleeding, you're done. Now call GI, get them up to the ICU. This can be left in place for up to 24 hours. If there is ongoing bleeding, you now need to proceed with insufflating the esophageal balloon. So this is them measuring to the pre-marked G and then suctioning out to check for bleeding. So to inflate the esophageal balloon, you need to have an insufflating manometer available. If you don't have one, you can't inflate because there's risk for esophageal rupture. You want to move the OG tube back to E, because otherwise you'll be inflating the balloon against an OG tube. And then you're going to attach the insufflating manometer, like so, to the 3-way stopcock on the esophageal balloon port. You insufflate to 30 millimeters of mercury and you close. And then you're going to suction again and check for basically bleeding above the esophageal balloon. If there's no continued bleeding, you're done. If there's continued bleeding, you can insufflate up to 45 millimeters of mercury and you'd repeat. Mark the location of the Blakemore tube with a permanent marker. And then at this point, you basically, they could go to the ICU. A lot of times what a GI would do is they leave it in place they can leave it in place for up to 24 hours. And then in a controlled environment under like direct visualization with endoscopy would basically deflate the balloons to see if there's tamponade or if the tamponade of the bleeding, or if they need to intervene in the suite to stop whatever or band or ligate whatever is bleeding. But they can go to the ICU like this. They can leave it in place for 24 hours. So some learning points. Timing of the placement is important. It's actually better to do it earlier if you're having evidence of massive hematemesis. We do have, GI on board in our hospital, but even still, sometimes they'll say they're too unstable to go to endoscopy. This is something that we're able to do in the ER and has pretty good success if deployed properly. You want to intubate prior to placement and ensure adequate sedation of the patient to mitigate any risk of aspiration, which is a complication that people are worried about. And then you always need to confirm the placement of the gastric balloon with chest x-ray, or you can use ultrasound before fully inflating, and this will mitigate the risk of any esophageal rupture. There are my sources. Any questions? Yeah.
So I don't think many people have put this in. They're rather difficult to get in.
It's really hard.
All the measurements you mentioned are sort of unhelpful because the tube is very soft. And even if you make it cold before you put it in, as soon as it gets soft, it heats up.
Yeah.
It becomes soft again, so it doesn't really hurt. But you have to usually what I'll do is I'll stand on my back to the patient's feet and I'll put my fingers down in their esophagus. This is why it's really important to paralyze them so they don't bite you. That's so you get them from aspirating so they don't bite you. But you're going to stuff it down using your fingers inside the esophagus. And you're going to push down as far as you can get it. The numbers don't matter because when you push it in, it's going to sort of flow back and forth and it won't be straight. So the numbers you measure are not going to be real numbers and it won't be helpful. But push down as far as you can get it and shoot the x-ray is really important because the balloon is the bottom balloon, the stomach balloon is very large. If you blow that up in the esophagus, you're just going to burst their varices and they're going to die right now. So it's super important to get that in the right spot. But it's very difficult to get down. It's very soft. It takes a long time actually to inch it down and push down into the esophagus.
For those at home, Dr. Silverberg was saying when he's placed this, he's used basically is making sure they paralyze his fingers to sort of stuff the Blakemore tube down the esophagus. When we were trying to place it with that one patient, it was really, really difficult. We also had difficulty finding the supplies, and we even getting in the same difficulty having the air being held by the balloon, which was a whole nother story, but it took a long time. It's not as simple as placing an OG tube.
That's another thing too, is you put the stop box in the end, take a zero silk and tie them below the cuff of the stop box. So the red rubber is sort of clamping down and holding it, otherwise the air will leak. Yes. Or the stop box will just shoot out. So you just put a silk on it with a tie and make sure it's really tight so the stop box doesn't pop up.
Thank you. Any other questions or comments? Does anyone know if we have it at UHB?
I believe they're in the cabinet.
Okay.